My name is Lisa Zimmerman. I'm from the Rehabilitation Research and Training Institute in Albany, New York. Thank you for joining us for today's webinar, Aging in Place, Developing Appropriate Community-Based Supports. These professional development webinars, which are presented in conjunction with RTI and the Lewin Group for social workers, counselors, registered nurses, and other healthcare professionals, are supported through the Medicare-Medicaid Coordination Office, or MMCO, in the Centers for Medicare and Medicaid Services, or CMS, to ensure beneficiaries enrolled in Medicare and Medicaid have access to seamless, high-quality health care that includes the full range of covered services in both programs. To support providers in their efforts to deliver more integrated, coordinated care to Medicare and Medicaid enrollees, MMCO is developing technical assistance and actionable tools based on successful innovation to care models, such as this webinar series. To learn more about current efforts and resources, please visit Resources for Integrated Care at www.resourcesforintegratedcare.com for more details. Just a little housekeeping before we get started. Your microphones will be muted throughout the presentation. However, there will be question and answer portions during this webinar. So if you do have a question, please click the Raise Hand feature on your control panel at the designated time, and you will be unmuted by an administrator. You can also type your questions into the chat window, and an administrator will ask the question out loud during that designated time. There will also be poll questions throughout the presentation. A window will appear with the questions, and you can submit your answers at that time. At the conclusion of the webinar, a tab will appear in your browser prompting you to complete the evaluation survey. It is required that you complete this evaluation survey in order to receive 3 contact hours each from the Michigan Social Work Continuing Education Collaborative, New Hampshire Nurses Association, the National Association of Social Workers, and the National Board for Certified Counselors. Please note that these are not CEUs, but rather contact hours, which can be translated to CEUs. You need to verify with the appropriate credentialing organization as to what would apply for your particular state license agreement. Requirements, rather. Also, it should be noted that contact hours from the National Association of Social Workers are not recognized in the states of California, Michigan, North Carolina, and West Virginia. If you are unable to complete the survey at the end of the webinar, you will receive an email tomorrow with a link to complete the survey at that time if you have not already done so. So at this time, I'd like to introduce our instructors to you. Jill Dorsey is a licensed clinical social worker who has over 30 years' experience working with individuals with mental illness and developmental disabilities, including individuals above age 60 in community-based family residences. She's also a trainer in person-centered planning, cultural competence, and recovery-focused practices. Linda Anderson is a registered nurse screener for HealthQuest Thompson House, where she meets and reviews patients in all area hospitals as potential rehab candidates in subacute rehab, and is PRI and screener certified. She was previously employed as a CMNH at Taconic DDSO for 20 years in the Family Care Unit and 15 years at Helen Hayes Hospital in acute rehab. Ms. Anderson is also a member of the Bereavement Committee at Taconic DDSO and a Prader-Willi educator, as well as participant in IBR study on Fragile X and Down Syndrome and Alzheimer's disease. And we can begin.
Hello, everybody. I'm Jill Dorsey. I'm a licensed clinical social worker, and I'm here with Linda Anderson, who is a BSN RN, and we're very happy to be here with you today. When we designed this presentation, we tried to incorporate the nursing perspective along with the social work and counseling perspective, and this collaboration facilitates a more integrated and comprehensive approach to all practices. The presentation will also take a comprehensive approach. We will integrate 2 themes, providing supports for people with intellectual and developmental disabilities who are aging, and we're going to be doing this from a strengths-based focus. We're going to be looking at how to assure safety and oversight while preserving quality of life. And the approach we're going to be taking for accomplishing this is individualized and person-centered, with the goal of assuring that the person's wishes and goals for himself or herself remain the focus of all the interventions. There's a great deal of research available on these 2 initiatives. We will look at some of this and also provide resources for you to use in continuing to learn more. There are PDFs of the handouts that have been included with the presentation, as well as suggested reading and resources. And you can also download these from RRTI and the Resources for Integrated Care website. The learning objectives today are to describe the benefits of aging in place, become familiar with principles of self-determination and person-centered planning, identify safety concerns and staffing supports necessary in designing a community-based environment for an aging adult with intellectual and developmental disabilities, including environmental modifications, to be familiar with Olmstead, the Affordable Care Act, and the American with Disabilities Act. Learning objectives continued, to identify resources for accessing necessary supports, including community agencies, family networks, and faith-based communities, and become familiar with issues caregivers confront as part of providing supports to aging individuals with intellectual and developmental disabilities. So identifying and developing supports for aging people with intellectual and developmental disabilities is becoming increasingly necessary. Advances in medical care and overall improved community integration and care results in an increased life expectancy across the board for people with intellectual and developmental disabilities. For example, in the year 2000, there were 641,000 people with IDDD above 60 in the United States. People with IDDD now have an average life expectancy of 66. Some statistics actually show that that is as high as 72. And people with Down syndrome, who are typically more fragile, once had a very limited life expectancy. For example, in 1930, most were expected to live to about 9 years old, and it has now increased to 60. Concurrently, caregivers are also aging. Living longer also means that individuals will need support that evolve in order to address their changing needs. Changes in living situations may also become necessary as well, particularly for those individuals who have lived with family members. And statistics indicate that there are about 75% of people with IDDD who are living with family members, and that estimate is about 480,000 individuals. As family caregivers are graying, in some situations there are two-generation elderly family members. Both the caregiver and the care recipient are over 60, and both are at risk for health and cognitive issues that are associated with aging. Caregivers may no longer be able to provide the same level of care to the family member. In fact, in some cases, the person who used to receive care becomes the caregiver to the aging parent. And the result is often the need for a new residential arrangement. What we want to look at is how to avoid doing that in a way that's actually a crisis.
In considering the implications of aging for people with mild to moderate IDDD without secondary syndromes are much the same as for people in the general population. People with mild to moderate IDDD age at the same rate in the same ways as people in the general population. They have similar longevity, aging affected by lifestyle, genetics, general health habits, historical medication use. Age-related changes often include reduced vision and hearing, pain in joints, weight gain, discomfort due to menopause, susceptibility to illness, and age-related conditions, much the same as the normal population. Some people experience accelerated aging associated with specific developmental syndromes. People with Down syndrome and cerebral palsy have increased risk. People with Down syndrome often experience an accelerated aging, increased risk of dementia, hypothyroidism, gastrointestinal issues, atlanto-axial instability. 25% will be affected by dementia after age 40, 50 to 70% after age 60. People with cerebral palsy, age-associated complications as a result of chronic immobility, increased contractures, increased risk of fractures, additional mobility challenges as they age. Early planning conversations are especially important for individuals who are at risk for developing dementia. You should have your discussion should include consideration of special accommodations that will become necessary as cognitive functions decline. Environmental modifications are likely to be necessary for people with cerebral palsy as mobility problems increase with age. Environmental supports and modifications will be necessary to allow aging in place. For some, the need will be sooner rather than later. and it's best to begin planning early.
So we'll look at some of the enhanced residential supports. As people age, it's likely that they will need increased hands-on assistance to complete their tasks of daily living or personal care skills, and including those skills that they used to be very independent with. So as they age, their skill level is going to decline. And safety at home may also require environmental modifications to accommodate people who are having increased difficulty with ambulation, declining vision or hearing, or impaired cognition. In the beginning, you should be discussing strategies for supporting individuals as they age. It's important to consider the need for additional hands-on supports, how they're going to need help with bathing, dressing, even eating, at a more structured residential setting, perhaps one that's designed specifically to support people with age-related concerns. That might be a residence that has 24-hour nursing availability, extra staffing, for example, and a lot of environmental modifications such as ramps. Appropriate level of supports can help individuals to maintain their existing skills as long as possible while avoiding accidents and injuries that may jeopardize aging in place. So where do we want to begin with implementing practices that support people who are aging in ways that respect individual integrity and choice, assure personal safety, and focus on continued community life and community-based supports? The Edinburgh group was convened in 2001 in Edinburgh, Scotland, and it was a collaboration between 3 universities, Stirling University in Scotland, the University of Albany in Albany, New York, and the University of Illinois in Chicago. They developed what is now known as the Edinburgh Principles. These are internationally applicable practices for developing community supports for people with IDDD and dementia. Even though these focus specifically on dementia, these principles offer a lot of valuable guidance for working with all individuals with IDDD who are aging. And there's a link at the bottom of the slide where you can access the Edinburgh Principles. It's a document. You can also just Google them on your computer, and you'll find them. They are pretty comprehensive, and many agencies use them as a basis for providing care. So the Edinburgh Principles are based on a 4-point approach: adopting a workable philosophy of care, adapting practices at the point of service delivery, working out coordination of diverse systems, and promoting relevant research. Our presentation is going to focus on 1, 2, and 3 of these principles, but it's important to note that relevant research is going on in this field all the time, and that new information, tools, and supports are being identified regularly. It's important to stay knowledgeable about the research and the results, because these provide invaluable resources for your practice. So I'm going to review the Edinburgh Principles. Adopt an operational philosophy that promotes quality of life. Affirm that individual strengths guide decision-making. This is also what we call a strengths-based approach. Involve the individual and family in all planning and services. Ensure availability of appropriate diagnostic and service resources. Plan and provide supports to optimize remaining in the community. Ensure that people with an intellectual disability have access to the same dementia services provided to people who are not disabled in the population. Ensure that community dementia services planning also involves a focus on adults with IDDD. Ensure generic, cooperative, and proactive strategic planning across relevant policy, provider, and advocacy groups. And it involves consideration of the current and future needs of adults with IDDD who are affected by dementia. Are there any questions? Lisa, has anyone?
No questions.
Okay. And as Lisa mentioned in the introduction, if you do have questions as we're going forward, please go ahead and type them in, and then there'll be an opportunity to also unmute and ask your questions personally. So in using the Edinburgh Principles as guidelines, we're going to focus specifically on quality of life, strength-based, person-centered planning, aging in place, and developing community resources. In doing this, we're going to focus on having a workable philosophy of care, a commitment to quality of life. We're going to be trying to preserve strengths instead of focusing mainly on the person's deficits. We're going to talk about how someone can age in place by adapting the practices at the point of service delivery. And we're going to be talking about building circles of support so that we can coordinate diverse systems. Quality of life is an important consideration for someone who's aging. We're going to be considering the negotiable elements in developing and implementing supports and how the person's individual quality of life can become the guiding principle in the process. Okay, I think probably the most important part of assuring quality of life is respecting what's called the person's personhood. And I'm going to just read this quote by R.M. Lawrence because I think it captures everything that we're trying to accomplish. Being a person is the fundamental philosophical and sociological position of a human being with value, intelligence, a history, and a present. The challenge in dementia is to continue to seek for and not to dismiss that person. And I think even though this is written specifically about dementia, I think this includes all aging individuals, so it's important to keep that in mind. Consider each individual within the context of his or her personhood, not as a member of a group of residents or old people or consumers. Each person is tied to his life by his or her connections to family, friends, religious and spiritual beliefs, hopes, dreams, goals, and aspirations. Each of us is a person, and we're defined more by what we love than by the various challenges that we encounter in life. The quality of our lives is most often defined by the things we enjoy, by our interests, our talents, our abilities, and our relationships with the people that we love, than by the things that we can't do. So preserving these is really a way to preserve our personhood, and it's integral to assuring quality of life.
Some ways people identify quality of life is remaining active, doing the things they enjoy, including their work, their hobbies. This also preserves skills and strengths. Maintaining social relationships with friends and family, sharing their lives with others, having a community support around them, people to share their interests with. Staying involved in community life, living in their own homes, whether it's a group home, a personal residence, or with a family. These are the areas people most frequently identify as important to the quality of their lives. It is important to note that things like managing my disability, taking my medication, going to the doctor are not the first things people consider when defining quality of life. Quality of life is impacted by aging. Complications of aging create physical, behavioral, and cognitive challenges and often involve a loss of function, loss of friends. Close friend or family may die. They may need to move to another home. This impacts their lives, and it's a whole grieving process around changing your environment. Changes require adjustment to new routines and environment. Age-related issues often result in a loss of independence, and they may no longer be able to continue their work. New needs associated with aging cannot be avoided. These will impact considerations in assuring that elements associated with quality of life remain intact. Additional challenges. Aging processes can be very difficult to understand for anyone, and especially someone with an intellectual disability or a developmental disability. It often inhibits a person's ability to understand the changes that occur as part of their aging. Some may have trouble cooperating with rehabilitation and environmental supports. They don't understand the benefit. They don't like the discomfort. Declining abilities and losses are confusing. People may feel anxious and frustrated without understanding why. The individual may be able to talk about the things that are important to his or her personhood and quality of life, yet still have difficulty understanding the implications of growing older. How aging may create challenges in walking, vision, and feeling confident in yourself.
So I know, Linda, in the practice, when Linda and I worked together, oftentimes people would go to a rehab facility and they would have something like a broken leg or some ambulation issue that really could have been addressed with rehabilitation, but the struggle was not so much in getting that bone to heal, but getting the person to feel like it was okay to go along with that pain while it was during the rehab process. They just didn't understand that this is what would help them get better.
And the process took that much longer to get to participate in rehabs because they don't understand the benefit versus the discomfort involved.
So another thing that may happen as people age is that new behaviors may emerge. As individuals struggle to cope with growing older and the changes that brings, they may express their fears, their sadness, their anxiety through new behaviors that are not typical for them. It's essential to consider these not as something that needs to be managed, but more as the person attempting to communicate and cope with his or her understanding and feelings of grief or loss or even just fear about what's happening. Some of the behaviors that you may see is that a person who used to be very social may begin to isolate himself and avoid social contacts. People may become self-abusive. They may be some self-injurious behaviors, hitting themselves, biting themselves. You may see anxiety and agitation. There may be angry outbursts, or a person who used to be, used to get along really well with other people may become aggressive and argumentative, and the person may seem to lose interest in their activities. It's really important that you don't focus on that behavior per se, but rather partner with the person so that both of you can try to understand what's going on and what the person is trying to express with those behaviors.
Routines are very reassuring. External routines provide a tool for orientation. Things like sometimes people tell time by, is it breakfast, is it lunch, is it dinner? Familiar environments support the aging individual to feel at home. Telling time for a young man on my caseload, Jeff, he lived with his father. And he had a very specific routine. Bedtime was associated with, you watched the 11 o'clock news. That was when bedtime occurred. His father was hospitalized, and he had a very difficult time when he had to stay with his sister in his sister's house because bedtime in that house, because of many young children and routines to get to school, was 10 o'clock, and he embedded himself on the couch and was not going to leave until that 11 o'clock news showed up because that was his routine and that was reassuring to him. So eventually she had to kind of bend a little and rearrange the routine until Dad got better and came home because this is what made him comfortable.
So in protecting quality of life, we want to continue to also support personhood. And keep in mind that our identity, how we see ourselves and how we prefer to have others see us, it's one of the ways we define who we are as individuals. This social identity also defines how others understand who we are, how we are perceived as individuals. And as aging begins to impact a person's relationships and abilities to interact with the world around him or her, both the person and the people in his life may begin to lose sight of who that person is as an individual. So you want to support the individual's right to make choices and decisions, and by doing that, you're supporting that person's ability to advocate for himself. Encourage individuals and their family members, their friends, their caregivers to talk about what they feel is happening. You know, bring that aging elephant in the room, so to speak, out into the open and really look at it. Listen carefully to their impressions of what growing older means to them. How are they experiencing it? Do they talk about not being able to see as well? Is that maybe why they're spending more time in a familiar situation? They're not as anxious or eager to go out into the community and do things they once enjoyed? Are they not sleeping well because they have aches and pains? Are they sad because they had to move to a new living situation and they're missing a beloved family member or even a pet? You want to guide the conversation to consider things that will be helpful. Avoid giving advice, but listen actively and suggest options and alternatives for the person to consider.
Changing appearances and abilities are a challenge to the way a person thinks about himself. For each individual, personhood is defined in a very personal way. Charlie was a 70-year-old man on my caseload that had mild level of intellectual disability.
I like the way you said he was young. I just want to say that. But by our perspective, he is young now.
My perspective, he was 70, still young. But he still worked in the community, took a great deal of pride in his personal appearance. He was always well-groomed, well-dressed. And one day he had a sudden loss of vision, and we took him to the doctors, and it was related to a melanoma in the eye. it was isolated to the eye, but the solution for him, unfortunately, was a nucleation to remove the eye. Charlie ended up wearing a patch, going through surgery, all the discomforts, and tolerated everything. Never once complained or talked about what this was doing to him until we took him. And many people on my case that worked with me said, well, what does he need a prosthetic eye for? He can just wear the patch. He doesn't need to have this. How is he going to learn how to maintain this prosthetic eye?
That's like an example of not respecting Charlie's personhood.
Right.
They really, but you were a strong advocate, Linda.
Well, we took him to an ocularist, and he was fitted for a temporary fitted for an eye, and we gave him to put the mirror in front of Charlie, and when he looked in the mirror, he looked at both of us and he says, "It's me again," because he was so devastated by the change in his appearance. He didn't understand, and no one ever thought until that moment to ask Charlie what he wanted or how he felt about the change in his appearance. And he did learn very well how to take care of that prosthetic eye. He valued it. He liked the difference it made in his appearance, and he felt like himself again, his confidence back. So just another thing to think about.
I've heard that story about, I don't know, many, many times, and it just always gets me going emotionally because it really made a change in Charlie's life to have that prosthetic eye.
Oh, yeah.
So you also, in providing strength-based supports for people, you want to collaborate with them, and you also want to take advantage of peer support. That can be very powerful. People are social and compassionate creatures. That's really in our nature. If you read any of the anthropological studies of human beings, we just by our nature take care of each other. Peer supports, learning about things together, sharing challenges and experience with people who are encountering similar experiences and challenges is invaluable. You can't overestimate how important that could be. Small group discussions can provide more support than you would anticipate because we are such social creatures. And being prompted to share and be empathetic when we understand that someone else is suffering can really help. You want to encourage people to talk with each other about their fears and discover ways that they can help each other. Many times that I've been working in congregate care settings, the peers understand this person has trouble, in the bathroom. A peer would come to me and say, can you help her in the bathroom because she has trouble seeing, or she has trouble reaching something in the bathroom. And that would be something I didn't know about, but, peers, they're friends, they're buddies, and they look out for each other. Don't be afraid to talk about death and dying. These are issues that everyone confronts. It's another elephant in the room. It's going to happen to everybody. And it's important to talk about it and let people voice their fears and their concerns and share them with each other.
And talking about it demystifies death and dying.
It does. It's a natural human process. So another thing that you can do that's really helpful is to create a circle of support. Now, those of you who are already working in person-centered planning and providing person-centered planning supports are probably familiar with circles of support. They're natural networks that all of us rely on as part of being persons within a community. One of the challenges associated with aging is isolation, including isolation from our natural circles of support. If we have decreased mobility or we're isolating ourselves because of health issues or visual issues, we have the chance of losing our contact with our circles of support. Become active in initiating and developing circles of support for individuals. Involve their friends, their family members, healthcare professionals, caregivers, and community members. Provide opportunities for that circle to come together on a regular basis, formally or informally, and the frequency of that circle coming together can be really driven by what the individual wants, the availability of the circle members. It doesn't have to be like every, third Thursday of the month you're going to meet. Let it be natural because our circles of support are natural. We come together naturally with people in our own rhythms. And this can support people to pursue their interests, preserve their strengths and abilities. A common circle function could be making sure that person gets to church every Sunday because that's what the person wants to do as part of his faith. They can also provide advocacy as needed. So are there any questions?
We do. We have a question from John. And John would like to know, is there an established correlation between the degree of quality of life, length of quality of life, and the setting and setting size, i.e. ICS, large group home, small group home, own home?
Okay, I can't quote statistics for you, but I have read statistics about people aging in place. And some of you may have been familiar with an initiative. It was a grant program a few years ago called, I think it was, I can't remember the name of it, but the study was that people were allowed to age in place, and funding was provided to natural caregivers. So, for example, if a wife became ill, if she had a stroke, and it wasn't limited to people who had IDDD, although they were part of the study. But if a person became ill, the family member could access funding to provide direct care. And the results of that were very positive. People felt more comfortable with getting intimate care from someone they already knew. People recovered and experienced rehabilitation more quickly because they were allowed to pursue rehabilitation in a natural environment. And at the break, I will look up the name of that initiative. It's no longer in place, but I'm sure you can look up the research and get more details on it. Oh, I think it was called Cash and Counseling. And I think there were 11 states in the country that actually did pilot programs on it. So if you Google Cash and Counseling, you'll be able to access that research. No more questions? All right. Okay, so person-centered planning. Person-centered planning plays a starring role in developing and adopting a workable philosophy of care. It's key to respecting the individual's personhood, which is an essential piece of preserving the person's autonomy and integrity as an individual. Often caregivers and others believe that age-related disabilities and needs are defined by what the person is no longer able to do. The focus becomes on safety, minimizing risks, and so forth. And this actually serves to increase dependency. So it's important to balance safety concerns, which I'm not saying to disregard them, but I'm saying that they need to be balanced with supports that are designed to preserve and enhance existing strengths and to help the person to manage and feel comfortable with age-related issues, especially fears, anxiety, and loss, and to continue to enjoy life. That's a huge part of quality of life. So what is person-centered planning? The person is involved in all aspects of his or her care planning, and he can also involve people that he or she chooses himself to be included in that care planning. So it can be family members, it can also be staff members, it can be community members, it can be peers. The person really has that capacity to identify the people that he wants to help plan his care. And the plan evolves from the person's choices and preferences. Again, it's strength-based. If the person likes to go out shopping on Saturdays and then see a movie, that should be something that's addressed in the plan of care, and you should be looking for supports that are going to enhance and facilitate that. If the person needs supports to do that safely, those supports should be put into place because the supports enhance the person's ability to do the things that he or she likes to do. So you're providing supports, but you're doing it in a way that focuses on what the person likes to do and what the person can do, as opposed to kind of matching them up with what the person can't do. The person can't walk, I'm going to give him a walker. That's one way of looking at it, but you can also say the person likes to go into the shopping mall every Saturday, but it's hard for him to walk, he gets very tired, so I'm going to explore getting a wheelchair that I can pick up when we get to the mall so that he doesn't have to walk so far.
Or a rollator walker with a seat.
Or a rollator walker with a seat. So I love working with you, Linda, because you know all the other options that there are. And, if you are working with home and community-based waiver services through Medicaid, Medicaid now requires that anybody who's providing HCBS waiver services is doing that by developing a plan of care that's person-centered. So the person-centered planning process is driven by the individual. The person is at the center. It's strength-based and outcome-focused. And when I say outcome-focused, what I mean is that the person identifies, I want to go to the mall on Saturday, and what you're going to be measuring is that person's capacity to have gone to the mall, every Saturday of the week, if that's what he wants, or 2 Saturdays a month. That's your outcome, that strength-based outcome. It includes the people that the person has identified as being important to him, and it supports the person to direct the process as much as he or she is able to do. So in the person-centered planning, you want to guide the person to consider and address the important issues in his life. So as I said, we don't want to ignore health and safety issues, but we want the person to be a partner in identifying what they are so that the person is more likely to understand them and cooperate with them. They're going to use them. The person understands that, well, if I don't wear my glasses, I might fall on the stairs because I don't see them coming. The person's going to be more likely to use his glasses. So you want to include health and safety protocol in person-centered planning, but you want to partner with the person as part of that. You also want to support the person as much as possible to choose how he's going to receive supports and from whom he's going to receive support. So when I was answering the question earlier and I talked about that cash and counseling program, one of the things that came out of that was how important it was to have a familiar individual providing intimate care supports, or having somebody that the person really enjoyed being with, going to the movies with him. So, if you go to the movies with somebody who's really interested in the movie and is having a good time, it's going to be a lot more pleasurable than if you go with somebody who's only going to that movie because they're getting paid to do it. You want to review the person-centered plan regularly, and your agencies probably have a protocol for how often they want a plan of care reviewed, but it should be at least annually, and I would highly recommend that it's much more frequently, and it should be at the individual's convenience. You don't want to review that plan of care without circle of support members being involved and without the individual being there. It should be sensitive to the person's cultural background and spiritual beliefs. Some people may need assistance with language. You want to provide, if the person speaks Spanish, you want to provide that plan of care in Spanish and have access to translation if necessary. And you want to use straightforward language. Don't, avoid using clinical terms and acronyms because they may be meaningful to us as practitioners, but they may be very intimidating to the person or to his family or caregivers. So just to review, person-centered plans empower the individual to be autonomous, particularly in making life choices, including end-of-life plans, which we'll be talking about in more detail. They ensure the person's rights to privacy, dignity, respect, and freedom from coercion and restraint, because they're really putting the person in the driver's seat. That person has control over his or her life. And they support and facilitate the individual's choices around services, service providers, and caregivers. And that's the real value of a person-centered plan.
Principles of self-determination form the foundation of a person-centered planning. Consider these as part of developing a plan for a person who's aging. The principles of self-determination are freedom to plan a real life, exercise the same rights as all citizens, authority over resources, their choice, their ability to choose, support to build a life in the community of choice, choose caregivers who will offer support and respect, responsibility to be fiscally responsible and to contribute to one's community in a meaningful way. And what is self-determination? Self-determination refers to a characteristic of a person that leads them to make choices and decisions based on their own preferences and interests, to monitor and regulate their own actions, and to be goal-oriented and self-directing. A person acting in a self-determined way has a voice in the decisions that affect them and is causing things to happen in his or her own life. And just was a very nice quote.
This conceptualization of person-centered planning represents the person as being in the center and then reaching out to capture the things that are most important to him or her. And these represent the person's relationships, spiritual and religious beliefs, hobbies, friends, community, what he likes to do in the community, health, and friends. And, you know, I want to point out that if the arrows are going out, so you're not confining the person by the things that he needs. Again, it's the person making choices for the things that he wants to reach out and to incorporate in his or her life.
For people who are aging, age-related challenges have a significant impact on the choices a person makes and the supports the person needs. So when you look at the graphic, all the things going out are their choices, but the challenges are the arrows coming in. So, you know, if you have, like, health is you want to have good health as a choice, but then if you have health-related care issues, they start to impact how you can make those health-related choices. If you want to live at home and you have an aging caregiver, that may not be possible to continue to live in that home, and someone would have to work with adapting to a different setting. You know, there are you want to be with your friends, but your friends live in an area that has steps and you need a walker and you can't get there. There's a fall risk involved, so those are things that maybe there's a different place that you can meet your friends. You know, you have someone who has passed away, one of your friends, your caretaker, then you're dealing with bereavement, and those are issues that require counseling and supports, additional supports. There are many syndrome-specific issues, like we talked about cerebral palsy and the mobility challenges, that affect where you can go, where you can work, where you can live, who you can go visit when you want to see your friends, where you can visit them, what kinds of activities you can do because you've been impacted by mobility challenges. As you age, there can be visual challenges or visual impairments, glaucoma. Charlie, we talked about, he had a melanoma and a retinal detachment, and he had to adjust to his visual field being halved because he no longer had vision out of his right eye, only his left. They're all things that meant we had to adapt to the environment for him. He lost his depth perception because he now had one eye to see out of instead of two. His visual field had changed. There are communication challenges with people with intellectual disabilities and developmental disabilities. They may already have had speech difficulties, and as you age, those dementia can impact what your capabilities for communication are. Memory loss can affect the ability to communicate, how you communicate, who you remember. So age creates quite a number of challenges to your control over yourself and your environment.
And I think in providing person-centered planning, what you really want to do is to create a balance. So you keep in mind the things that are really desirable outcomes for the individual to, you know, visit the friend or to have the friend or family member. So you want to provide supports around those health issues so that the person can continue to enjoy the things that are really important to him or her.
Empowering an individual to make informed choices about his or her care and life may become compromised by health and cognition issues associated with aging. And it's important to start all those conversations about what kinds of adjustments you may be facing early while that person still has their cognitive skills and can comprehend what you're discussing. Empowerment to make decisions may be compromised by health and cognition issues associated with aging. Initiate those collaborative conversations with the person to acknowledge and cope with the losses, the health issues, and the planning.
You're developing a person-centered plan of care, you want to be careful to use what we call person-centered language. You know, the person isn't a developmentally disabled person, it's example, if you say to someone, well, I think you have a cognitive impairment, that may not be as meaningful as if you say, are you experiencing some confusion? You seem like you're a little confused about where your bedroom is, and you used to remember how to get there. You say, instead of impaired ambulation, talk about difficulty walking. Does it hurt when you walk, or are you having trouble maintaining your balance? Instead of depression, are you feeling sad? Are you feeling lonely? When you talk about increased agitation, do you get upset easily? Words that are very common language for someone who's a practitioner may not be easily understandable for somebody who doesn't do this all the time, who doesn't talk about this stuff all the time, who is instead rather experiencing it firsthand as something that they're going through. So when you're developing a written plan of care document, avoid these as much as possible, because you're going to be sharing that written plan of care with the individual, with his caregivers, and with his family, but you still want to remain in compliance with the regulations and policies of your agency. So again, it's another balancing act. If you want to, if you need to use very specific diagnostic terms to justify a plan of care and indicate that the person does, if you're justifying medical necessity, of course you have to use those, but you may want to combine them with a description of what that means, so that you're providing care because of a cognitive impairment that's going to justify medical necessity, and you're going to explain this is because the person is easily confused when navigating in his residence. And that way the person understands it, and you also meet the regulations and requirements of your agency.
Okay, it is important to discuss future plans as soon as possible to accommodate declining health and cognition of individuals and their caregivers. There are a variety of tools available that are designed for developing advanced directives for people with IDDD. These available from several sources. NYSARC provides information on guardianship and advanced directives. Documents are designed for use with people with IDDD and their caregivers and families. 5 Wishes is a step-by-step manual to develop advanced directives. And Advanced Healthcare Directives is an informational booklet on healthcare decisions. You can access them, retrieve them from www.nysarc.org. And we will discuss more of this as we go further on in the presentation about these tools. Advanced directives are different depending upon the state you come from, so check the state requirements of your own state.
So to review, preserving personhood, remember who the person is. Support the preservation of who the person is. Aging and the changes and challenges associated with aging are things that happen to the person. Remember that personal identity is most often expressed through sentences using I. If the person is no longer able to communicate in that way, it's going to compromise his or her personal identity. Some age-related illnesses and challenges can make it difficult to preserve the individual's personhood, particularly if the person is no longer able to interact and socialize with other people. Personality traits often define who the person is in our minds, and the way the person presents himself socially usually defines himself to others. And as these become obscured through illness and dementia, the person just becomes someone who is sick or someone who has a lot of needs. And we really want to avoid that, because it's going to impact the person's personhood. It's going to impact the quality of life. We really remain the people we are through life, even though illness happens to us, even though we become disabled in a certain area where we used to be competent. So it's important to keep those things in mind.
You need to keep the person at the center of aging support. Aging and dementia do not define who the person is. They are what happens to a person. Develop advanced directives and plans for the person while he or she is able to participate actively in those plans, while they're still able to self-advocate and communicate. New behaviors may be efforts to express pain. Consider that. Fear, anxiety, new territory for a person and the practitioner. So look at a new behavior as a possibility that there's something else going on. Continue to communicate with the person even when it becomes difficult to communicate.
So we talked earlier about demystifying death and the aging process. Begin those conversations as soon as possible, and do it in a really straightforward way. Early intervention is the best. do it while the person can still engage in the conversation. Be frank, be open, be clear. Talk about how aging is affecting the person. You know, does he feel bad because he looks different? As with Charlie, I mean, when he had a patch over his eye, he felt like he wasn't himself anymore. How do they feel about their health, their stamina? Are they noticing that maybe they're getting a little forgetful? Initiate discussions about the person's wishes for new supports and living arrangements. And this is going to, just by its very nature, include conversations with the caregivers. Encourage caregivers to discuss their own aging issues and their concerns and how this is going to affect their future ability to care for the person. Many caregivers may have already identified a sibling or a cousin who would want to step in and care for the person, or at least be an advocate for the person. But it's important to find out what these are and document it before it becomes a crisis. And encourage caregivers to discuss their own aging issues and abilities. I mean, if caregivers are beginning to have heart problems or mobility problems, or thinking about, moving to a warmer climate or whatever, you want to know that, because you want to start preparing the individual for a change in his or her own life. Maybe he's going to need to move. Maybe he's not going to be able to see his family member every week or as frequently as he used to. And rather than springing it on the person unawares, you want to start that conversation so that the person is prepared. So where do you begin? Talk about, where do you want to live if you can't live with mom or dad? Do you want to live in a small house? Do you want to live with another family? Do you want to live with people you know from work, with your friends? What things are really important for you where you live? Do you want to have your own room? Is it important for you to live with people you already know, or you want to make new friends? Do you want to be close to shopping? Do you want to have your own TV? Talk about, who are your closest friends? Who do you eat lunch with at work? How important is it for you to have them visit often? Remember that dementia and ill health can change the way a person socializes. And that person who used to be really social may now want to have more quiet time. Also be aware that isolation may be a symptom of depression, and try to tease that out when you're talking to the person. If you're asking about their closest friends and how often they want to see them, and they say, I don't want to see them anymore, and that's a good clue that something else is going on that you're going to want to examine with the person a little more closely. Talk about what things the person likes to do. Does he like music? Is it really important for him to have an iPod that he can listen to? Or does he like to do crafts? Is the person a knitter? Does she like to crochet? Do they play video games? Is it important to have somebody that they're living with who also likes to play video games, or do they prefer to play them on their own? Ask what they like to do during the day. Do they like to work, or do they want to have like a quieter life, maybe spend some of their free time going to yard sales or concerts or the movies? If they're working, ask them if they want to develop a retirement plan. There are options in many communities for people to go to, I guess you'd call them like geriatric daycare centers or day habs. It may not necessarily be specifically designed for people with intellectual or developmental disabilities, may be designed for people who are just elderly. And people can fit in very well with that many times.
We've had many day habs, adult day habs, that we've intermingled people with IDD and people aging from the community.
Because in many times they have a lot in common.
Feel kind of levels as you age.
Feel levels, and also, you're dealing with the same issues. You're dealing with issues of aging, and that ability to achieve landmarks is no longer as important. So really kind of, in talking to people, put everything out on the table and really look at all the options that are available, and be as creative and open-minded as you can be, and encourage people you're working with to do that as well.
Another thing that you can do is create a time capsule with the person while they are, able to express who they are, what they like, the interests they have. So you're creating a personal legacy from the person and to the person. Prepare before dementia starts. Individuals' experiences, their pictures, their memories, a scrapbook of things that are important. So if that person develops dementia down the road, they have something that they can look back to. I mean, everyone enjoys looking through a family album. Well, so does this person, and this is like a catalog of their accomplishments, the friends they have, their family, the things that interest them, the places they've been. Cultural and religious beliefs, should be cataloged. Their attitude, discuss attitudes about death and dying. What do they want? How do they want this handled? Who do they want to be with? Demystify it. Make it something that they can freely discuss and be comfortable about, not a frightening experience that they're dreading. Talk to them about their wishes around end-of-life care, advanced directives. What do they want done? Do they want a DNR order in place? Do they have certain things they don't want done, and no IV or feeding tubes? Do they understand what those things are, and how those things would have to be defined in a healthcare proxy and a DNR? Humanistic inspirations, ideals, arts, nature, things that appeal to them. Keep them in that time capsule that you're creating. It's their legacy of what they can pass on that someone can discuss with them. We have a patient that was on my caseload, Irwin, that he had to go to the hospital for an endarterectomy. He had a clot in his carotid. And the surgery is a little bit risky. The risk is a possibility of a stroke. The risk is, if you don't do anything, it's a possibility of a stroke. And there's also a risk of possibly dying after that procedure. And his favorite song, which he got everyone in the hospital to sing all the way to surgery, was "Jesus Loves Me." So he had a trail of nurses and social workers following him to his surgery. And we thought we had successfully dislodged the clot and that everything was fine because 5 days had gone by. He was about to be discharged, but he did not make it. And when he passed away, his friends and family got together at the funeral, and that song was sung. Jesus Loves Me, in honor of Irwin and the fact that this was something very special to him.
So, and it meant such a lot to his friends. Because they had lost a great friend. He was a really nice man.
Yes.
And it was really sad when he died. In fact, I got the call, and Linda was actually on the way to the hospital to pick him up. So, yeah. So it's important to know
what's special to someone.
What's special to someone, and that it's a respect for the person, but it also helps the people that person leaves behind to mourn him. So also talking about a person's likes, dislikes, and this isn't a sad story. So one of the people that we worked with was named Teddy, and Teddy, he only liked to eat white food, and this was something that I don't even know what the origin was. He was a very bright man. He read. He was able to read. I mean, his intellectual disability was very, very mild. He had a lot of outside interests. But he refused to eat anything that wasn't white. I mean, he would eat pasta, rice, chicken, but he wouldn't eat roast beef. He would eat fish. He would eat shrimp, but he just refused to eat any dark food. And it was so important that people who were working with him knew that, because if he went to the hospital and he was served something that was not white, he wouldn't eat it, and he would throw it. He would become quite agitated because he was a good self-advocate. I mean, he knew what he liked and he knew what he wanted. But instead of having him be seen as a, quote, behavior problem, it was important to say, this is the kind of food that Teddy likes to eat. And if he doesn't have this available, he's going to be hungry, he's going to be angry, and he's going to feel like you're not respecting his wishes. So it's just another example of how important it is to know who the person is and to really put that person at the center of your planning for him and get him to participate, because Teddy was very adamant that he wanted white food and that needed to be in his plan of care.
And we talked earlier about NYSARC has advanced health care directives that are designed for someone with cognitive impairments, so they're a little easier to manage and explain. They provide information in an easy-to-read format about choosing a healthcare agent, being able to explain that to the person. And these are all things that you need to do when that person has their cognitive skills, so they understand what you're asking and why. Choosing a healthcare agent is set in the form of life support treatments, like I talked about before, and explaining what is a G tube, what does that mean to have a feeding tube? Do you want to have this when if you're unable to swallow? There are choices that someone has to make in advance to have those wishes respected. signing and witnessing the document, how to explain it, what it means to have it signed and witnessed, changing the information, updating choices. They have a right to change that information. If they rescind who they specify in that document, it has to be done in writing, and someone has to know that they do have the right to change their wishes. Maybe they change their mind. They want everything done, whereas previously they said DNR, do not resuscitate. And you need to be able to share what those advanced directives are with other staff, other people.
I just want to point out that NYSARC is a New York State agency, and while this is a very useful document, it's important to make sure that what you put into place is acceptable in the state that you're practicing in.
The other form we discussed is the 5 Wishes, which is also a New York State form, but it happens to be accepted in, was it 50 of the states?
Well, it's actually not a New York State form. It was designed by a Florida organization called Aging with Dignity, and I think some of you may have tried to print out the PDF that was sent to you with the presentation, and you discovered that you can't print it. But if you go to the website, agingwithdignity.com, you will be able to purchase it if you want to use it, or you have the option, if you're actually filling one out for somebody, of doing that online, and I believe that one is free. But I'm going to have you go on, Linda, talking about that.
Well, what the 5 wishes are in this form is the person I want to make care decisions for me when I can't is identified. The kind of medical treatment I want or don't want is identified. How comfortable I want to be kept, how I want people to treat me, and what I want my loved ones to know, what those wishes are. It is in 50 of the states. In 42 of the states, it's accepted as the wishes of that person and respected as such. In some states, you would need to combine that form along with a healthcare proxy and a DNR to have it accepted. If you visit the Aging with Dignity website and review the document, you'll be able to access it, as Jill said. It can be used as a legal document with in 42 states and added to the DNR and healthcare proxy in the other states.
So, even if you're in a state where the 5 Wishes isn't seen as a legal advance directive, it is really a useful document to go through with somebody because it really walks the individual through step by step some of the issues that would be typically considered in providing some kind of end-of-life care.
Do you want to review a little bit of what's in the form?
I can.
On your iPad.
I'm just going to pull it up.
And like Jill said, if you want to utilize this form, it's a form that you would have to get consent to download.
So some of the things that 5 Wishes can do, there's a section there that it helps you to talk with your family and friends and your doctors about how you want to be treated if you're seriously ill. Your family members will not have to guess about what you want. It really generates a conversation around those end-of-life issues that can be so tricky and so difficult to talk about. And you can also know what your mom and dad and your spouse want. You can be there for them. That would be for someone who is maybe not a care recipient. Again, if you go on the website, it'll list the states. As Linda said, there are 42 states that do accept it as a legal advance directive. It talks about how I can designate a healthcare proxy, the person I want to make healthcare decisions for me when I can't make them for myself. Someone who is really ill or someone who may have diminished intellectual capacity can be walked through this. The language is, again, very person-centered. I'll share this with you, Linda. Even though it's my iPad, I'm going to share. We play nice. It really walks it through in language that's not intimidating. It's very clear. It's language that anybody can understand. Talks about how to pick the right person to be your healthcare agent. That can be very tricky. I know, you want your healthcare agent to really be someone who can put aside their own emotions and make a decision that may be painful for them, but they know it's what you want.
Well, like often something that happens is you assign someone to be your healthcare agent, and you have a wish to not be resuscitated under certain circumstances, and they're not able to follow through with that, and you're not able to speak for yourself. So it has to be someone that you've kind of designated that is able to follow through with your wishes, as Jill said.
So, you know, part of it may also be that the person would need to sign consent for the person to be, you know, the healthcare proxy would need to be able to sign the person into hospice if it looked like the person wasn't going to recover. It can be, you know, very.
And the other problem sometimes occurs is when if that person you picked as your healthcare agent moves out of state, are they still an appropriate choice? Can they get back to take care of what you've assigned them to take care of, or do you need to have a secondary person on there that's an alternate?
Another section of this, it's actually wish number 2, is my wish for the kind of medical treatment that I want or don't want. You know, do I want to be on an IV? Do I want to have resuscitation if my heart stops? If I don't want to be in pain. You know, I want to make sure I can get enough medicine so that I'm not in pain. And then maybe you can talk about what life support treatment means to me, Linda.
Well, life support can mean any medical procedure, device, or medication to keep someone alive, but maybe that's not really what they want. Maybe that person, all they really wanted is that access, they want to still be fed, you know, do they want a feeding tube or don't want a feeding tube? Do they consider CPR something they want? Do they want blood transfusions? Do they want to be put on dialysis, explaining what dialysis is? Do they want an IV and antibiotics? A lot of these things are things that slow down the dying process, and if ultimately that person is in a terminal situation, do they want those things followed, or do they want to limit what care is given? And do they understand what that really means?
And I think that's also the tricky part as practitioners, because working with somebody who does have an intellectual disability, you're going to have to work very closely with them to make sure that they're not saying something that they think they want without really understanding what it is. One of the things that I found to be really helpful is when explaining something to just stop and say, now, can you explain to me what I just asked you about? And many times, you know, you don't want the person just to parrot back your words. You want to hear from that person that they really have a sense of what you've said and that they're thinking about it.
And how you want to be treated also includes things like, you know, I've had someone tell me that they don't want to be alone when they die. They were aware that they were dying, but they wanted to know that someone was going to be there with them, to hold their hand, to talk to them, tell them that was important to them. Do they want to die at home? Do they want to be in a hospital? They're all considerations that may or may not be possible.
And then this also has wish number 5, my wish for what I want my loved ones to know. And, you know, that's just a list of, like, messages to people that are important, people in that circle of support who have really been meaningful to the individual. You can also include in here wishes that the person may have about ceremonies for funeral arrangements and so forth.
And do they want to be buried? Do they want to be cremated? They're all considerations that need to be, should be specified. The question should be posed if the person is capable of those decisions. Okay.
So it's a very useful form. If you can use it in your state as a legal document, that's great. But you know, you can just use it. You can read through it and actually help it to inform some of your conversations with individuals.
Okay, now hospice is also a choice, and it's a choice like in the 5 wishes that can be presented along with that form. Hospice takes care of difficulties with making decisions that does not preclude participation in advanced care planning. Hospice maximizes autonomy and decisions for better end-of-life care. You, as the person helping work with that your person on your caseload, need to be proactive about policy barriers like do not resuscitate orders or right to refuse life-sustaining care. If that person has cognitive skills to make a decision to not have a feeding tube, then they've determined to have the capacity to make that decision, then you need to actively promote that decision because that's what they really want.
And in your state, I'm sure there are regulations and policies around how to determine if an individual does have the ability to make an informed choice about his or her care. So you want to be aware of what those are in your state so that you can be not only an advocate, but an advocate who's advocating accurately.
And even if the person does not have capacity to make decisions around a DNR, decisions may be made through surrogate court or other means. Again, be aware of regulations in your state. If the person doesn't have capacity, he or she can still participate in working with hospice and making other end-of-life choices. And whatever those decisions are, they need to be promoted with collaboration between the caregiver and the person, because caregivers also have opinions about death and dying and may not be the same as the person they're taking care of, what their decisions are.
So again, we can't stress this enough. You need to have frank and open discussions, even though in many situations it's a difficult topic. But in my experience, and I think Linda and yours as well, once you start talking about it, this is an experience that all of us go through. And once you do start talking about it openly, it does get easier. It's not a happier discussion, but it is an easier discussion. So I want to share with you the story of Fanny. And Fanny changed quality of life. She was a very bright woman. I met her in her mid-70s, just after she had been diagnosed with cancer. And Fanny had, she was diagnosed with cancer. It was already stage 4. And the oncologist told her that he would be able to extend her life by several months, but that she was going to suffer from the side effects of the chemotherapy, and it wasn't going to cure her. The cancer was going to probably be the illness that took her life. So Fanny thought about this for a long time, and as I said, you know, she had a mild intellectual disability, but she had a good sense of who she was and a good sense of what she wanted. And she decided that chemotherapy was not for her because it would compromise the quality of her life during those last few months. She was very open about the fact that she didn't want to spend the last month she had on earth feeling worse than she already felt. So Fanny chose hospice, and by advocating very strongly for her, we were able to support that choice. We did have to go to the medical director of the agency we were working for, and we did have to have Fanny interviewed by a psychologist who determined that, yes, she did have capacity to make that informed choice and to choose hospice instead of the chemotherapy that was going to, you know, may have prolonged her life, but it was going to seriously impact her quality of life. The other thing we talked about with Fanny was what she wanted to do with the time that she had left to her. And again, Fanny was like, she was such a delightful person. I'm always so happy that I got to be with her during those last months. She loved spaghetti and meatballs, so we went out several times a week to have spaghetti and meatballs. And in the beginning of her illness, she actually had a very robust appetite, and I was amazed. She was a little tiny lady, and she could eat like a huge, huge portion of spaghetti and meatballs and then be ready for dessert. She also really liked ice cream. She also talked about what she wanted in terms of a funeral arrangement. And Fanny had been placed into congregate care when she was a young girl. I think she was probably 10 or 11. And she had a best friend. And what she wanted more than anything was to be buried near her best friend. And her case manager spent a lot of time discovering where her best friend had been buried. And he was able to not get her exactly in a plot next to the friend, but very nearby in the same cemetery. So that was also a wonderful experience for her because she got to visit where her friend was. She hadn't known before where her friend was buried. She also got to see where she was going to be laid to rest. And I know, I mean, some people may feel, well, that's really morbid, but Fanny was really actively thinking about what was going to happen and what she wanted. And Fanny was Jewish. She wanted to be have her service said at the gravesite with a rabbi, and we were able to put all of that into place for her. So even though when Fanny died, it was so sad, and I mean, I get emotional just talking about it. But she did have what she wanted, and I feel like we really respected her choices. So on that note, we're going to ask, do you have any questions?
We have a question from Jackie. Jackie'd like to know how to differentiate between someone who's becoming isolated due to morbidity versus a personal choice of wanting to take things easier / retire from daily activities and commitments they have participated in most of their life.
That's a good question.
Yeah.
You know, I think, again, you're going to want to talk to the person. That's a very insightful question, Jackie, and I think you probably have good relationships with the people that you're working with. You want to spend some time about what the person is trying to accomplish with isolation, and you can really talk about it in that way. You know, when you go to your room to be alone, and you close the door and you don't want to have anybody bother you, what are you doing there? You know, a person may be saying, well, you know, they make a lot of noise in the living room, and I want to sit in my room and listen to my music quietly, or I'm crocheting and people are always asking me what I'm doing and they bother me, I lose count of my stitches. So, you know, if somebody's giving you that kind of an answer, you're going to realize, well, that's probably a choice the person is making around wanting some quiet time for himself. But if the person doesn't know why they want to be alone, and they're kind of shrugging their shoulders, and they're maybe having difficulty engaging with you in the conversation, to me, I would suspect that that may be some depression.
Or possibly dementia.
I was going to say maybe, you know, some of early dementia. I'll let you talk about that, Linda.
And those are things that I would suggest that that person be evaluated by a psychiatrist to make that determination. Are we dealing with a depression or dementia? And there are med choices that can be offered. There's programs that can be put into place to get that person to re-engage. Once you know, knowing the reason why they want isolation is how you start the process of what to do about it.
And, you know, I think Linda makes a really good point. I mean, you may evaluate the person as like in my case, I would evaluate the person within the scope of my practice as a social worker, but I would certainly want to make sure that the nurse and the medical professionals that I was working with were aware of the concerns that were being raised. So I may say, you know, Linda, you're the nurse. I really think she's just, you know, feeling like she wants some quiet time and the people around her are too noisy. What do you think? And, you know, that's another part of that circle of support where you want to get input from people who have different perspectives and different relationships with the individual so you can get a much more complete picture. No more questions?
Well, it's time for a break.
Yes, I think we have a break now.
And we will return in 10 minutes, so that will be at precisely 2:30 Eastern Standard Time. So we will see you guys in 10 minutes. Thank you.